Perfect. Well, we are going to present this with Federico. My name is Andres Pichon Riviera. I was a medical doctor in a previous life. I have been working in health economics the last 25 years. I am the director of IEX, the Institute for Clinical Effectiveness and Health Policy. This is an academic institution located in Latin America. And I am also professor of public health at the University of Buenos Aires. Fede?
Yes, well, I'm Federico Gustowski. We were colleagues with Andres in family medicine in our initial lives, and now colleagues in the health economics arena. I direct with Andres the HTA and health economics department. I'm also a professor at the University of Buenos Aires. And we work at IEX. IEX it's an academic non-profit NGO that is based in Buenos Aires, but works in all Latin America and LMIC settings. Very, very nice to be here with you.
So Federico, I think if you agree, I think that in case that you have questions or you want to say comment, please raise your hands and open your microphones, because we are not so many. So I think that will be okay. You can also leave your questions in the chat, but as we have a quite long presentation, I think it's okay if you want to answer a question in the middle.
Sounds perfect. Well, we can jump in our route map for today, no? Paul invited us to present initially one of the published works that we did in the last few years, and then we suggested to incorporate not only the efficiency idea, but also the affordability idea, or the affordability concern, or affordability guidance that we are also working at the moment. So we will start with the initial context or general cost context, and how it is important to have decision rules for informing health decisions or coverage decisions or reimbursements, etc. We're going to start with the efficiency idea, or the cost effectiveness thresholds, and our previous work. Then we will show you some unpublished data that we are working on at the update of this initial paper that we did a couple of years back. And then we will switch to the affordability question on the affordability section, and the budget impact thresholds that we are working at the moment. That we have a pre-published working paper, and then final remarks and questions, a segment for questions from the audience. But as Andres said, we accept questions alongside the presentation. So, as you all probably know, there are more new technologies that we can cover or afford or give access to our population, and this not only happens in LMIC countries, but also in higher income countries. We are all economists, so this opportunity cost and resource constraint is part of our Bible, and no healthcare system can afford or provide all the relevant or all the effective or efficacious health technologies. No? So it's always decide which is the least or the best scenario under these constraints. So how do we prioritize which technologies to give to the population in this context. No, for example, which vaccinations should we include in the national vaccination program, or which cancer drug? No, there was an explosion in the last couple of decades of new biologics, mostly oriented to cancer problems. Which one of them, if any, could we, or is it worth to be incorporated in our national benefit package or in our healthcare system, or which preventive or screening intervention should we provide? So here we have the old three hurdle systems, or the old, because we always grow incrementally, no? In all countries of the world, of most countries of the world, we have well-established three hurdle systems, no? Like the FDA in the US, or the EMA in the European Union, that they guard these three criteria, no? And they have decision rules, and after a new technology fulfills the safety, the quality, and the efficacy criteria, market authorization is granted, and they can be sold, they can be available in the different countries and markets. But then, in the last 20-some years, most countries in the world began adopting what is sometimes called a fourth hurdle system, no? That it's not only guard these three criteria, but also to think, if we have to fund the healthcare we provide, what things that we have value for money, no? Or cost effectiveness. So these are sometimes called fourth hurdle systems. And in the last decade or a little more, there was another economic aspect that it's intertwined with the cost effectiveness aspect, that has to do with short-term or medium-term affordability, no? That is measured by the budget impact analysis. So these two economic dimensions are the ones that we will talk about today, no? Our first set of studies tries to provide some rules or some guidance for countries to have decision rules for cost effectiveness, and the second study aims to provide some guidance or some order, give some order to the idea of possible affordability thresholds or budget impact thresholds, no? And of course, there are other social values or other relevant values that are increasingly being considered, no? Not only the economic and the efficacy or effectiveness aspect, but the equity dimension, organizational impact, sustainability, etc. No? Our webinar today concentrates in the two red or orange dimensions that are related to the economic aspects. So, as I said, there are well-established decision rules for the classic three hurdles, and are guarded by these regulatory agents all over the world. And there are more recent decision rules for efficiency and cost effectiveness, with different methods and proposals regarding the incremental cost effectiveness ratios and their thresholds. And still, we are in an early phase regarding the issue of affordability or budget impact thresholds that are used by a few countries officially in the world so far. And decision rules for the other criteria are still a moving target and still in the making. So just to start with the basics and the cost effectiveness plane. No, when we have a technology that is better in terms of population health and less costly to the system or to the society, we have no problem deciding. The rule is go ahead and do it. The problem is in the northeast quadrant of this cost effectiveness plane, what to do when we have the usual thing, new technologies that are costly and also more effective. So this cost effectiveness analysis comes handy and help us to have an orientation of which technologies are have good value for money or not in our context, in our country, in our healthcare sector sometimes. So we define this threshold, the diagonal line that you see there, and technologies that have a lower incremental cost effectiveness ratio have a good value for money, and those that have higher cost effectiveness ratio have higher value, a low value for money, and we would reject them in this if we consider only this efficiency aspect. And some history regarding the cost effectiveness thresholds. Maybe 20-some years ago, there was a classic recommendation by the WHO that suggested a certain definition of these cost effectiveness thresholds that now are rejected also by the WHO, who initially recommended them, but with a panel of experts. It was an expert recommendation. And now there is the evidence that has appeared in the last 10-15 years has shown that usually the threshold is about 1 GDP per capita, or usually less than 1 GDP per capita per healthy life year. Sometimes healthy life years are measured in QALYs, quality adjusted life years, or in DALYs, disability adjusted life years. So usually many studies that have studied this issue show that the threshold is usually below 1 GDP per capita per healthy life year. So in a few countries there were empirical studies that tried to estimate this cost effectiveness threshold using healthcare production data, as what the health that the country produces and the cost that it incurs to produce these countries. But in most of the countries there is no empirical or in-depth analysis regarding the cost effectiveness thresholds, and current methodologies are very complex, and data hungry. They require data that most of LMIC countries do not have. So that's where our study, that is based on using data widely available and open in all countries or most countries of the world, comes as a possible way to have a guidance regarding these cost effectiveness thresholds in settings where we cannot afford to do more complex or costly studies to derive them. So with that said, I pass the ball to Andres, who will take you to these efficiency thresholds or cost effectiveness thresholds that we worked and we are working on currently.
Thank you, Federico. Just to check, can you see my presentation?
Perfect.
Wonderful. So, well, good morning. Thanks again for inviting us to present our work here.
Maybe,
Hope it is
Federico,
not...
are you unmuted?
Yes, I am muted. Now Andres will.
Yeah, now it's okay.
Good.
Okay. But Pavitra, you can hear me, okay?
Yeah, you're pretty audible.
Okay.
Thanks.
Perfect. Thank you. So I hope this is not too boring, not too complicated. As Federico mentioned, we're going to present mainly two research that we were working. This one was published a couple of years ago, and I will focus mainly on the methodology component of the presentation. This is a work that we have done with our colleagues, with Professor Mike Drummond from York University, and Alfredo Palacios, Sebastián García Martí, my colleague Federico. And I think that one of the most important findings or components of our work was being able to quantify the link between the cost effectiveness of interventions and the evolution of life expectancy and healthcare spending in a population. And now I will explain this now in more detail. As we are going to talk about vectors, and I am not sure if you are familiar, just a couple of basic concepts. A vector it can be defined by two characteristics. One is the magnitude. For example, we can see here two vectors that have the same direction but a different magnitude. And the another characteristic is the slope of the vector or the direction of the vector. In this example, we can see here two vectors that have the same magnitude but a different direction. And the direction, the slope of a vector is defined by the vertical change and the horizontal change of the vector. For example, in this case, we can see here the evolution of life expectancy and healthcare spending in China. And we can see here that the horizontal change in this case is how life expectancy increased in China during, for example, 2016 and 2020. Life expectancy in China increased by around 1 life year. And in this case, the vertical change is the increase in health expenditure per capita that during this period increased by 37%. I am explaining this because we are going to discuss the influence of different factors on the evolution of life expectancy and healthcare spending as vectors. And the last attribute of vectors is that when we have two different vectors, we can zoom the effect and estimate a resultant vector. So even if we have 3 or 4 or 5 or 10 different vectors influencing the evolution, in this case of life expectancy and healthcare spending, we can summarize all these effects in a resultant vector. So now maybe it's easier to understand in this example. We can see here the evolution of life expectancy and healthcare expenditure in China along these years. And again, as I showed previously, during 2016 and 2020, this was the change in life expectancy and healthcare spend. So there were different factors during this period that influenced this evolution, and we cannot know all of them, and we cannot measure all of them. But so now I'm providing some examples. For example, the appearance of a new disease, we can imagine this as a vector that will point to the left and up, because it's a vector that will exert an influence to reduce life expectancy, that's why it's pointing to the left, and to increase healthcare expenditure, that's why it's pointing up. Another example may be, for example, in a country, improvements in education or in nutrition. This will be a vector that will influence this as a vector pointing to the right, because it's a vector, it's an influence that will increase life expectancy, because improvements in education and nutrition is a factor outside the healthcare system, but increase life expectancy, but that with no influence in this case on healthcare expenditure. This is just examples, not to understand the concept. So in any country, there are many factors influencing the evolution of life expectancy and healthcare expenditure inside or outside the healthcare system. But one factor is the inclusion and coverage of new interventions. If a healthcare system includes a new drug or a new intervention in the health benefit package, that decision will affect healthcare expenditures and life expectancy. And there is a relation between the cost effectiveness of that intervention and the influence that that intervention will exert on the evolution of life expectancy and healthcare expenditures. For example, as I am showing here, a cost-saving intervention will be a vector pointing to the right and down, because a cost-saving intervention will increase life expectancy, that's why points to the right, but also will reduce healthcare expenditure, and because it's a cost-saving intervention. Interventions in the upper right quadrant will be vectors pointing up and to the right, because will extend life expectancy and will increase health expenditure. But as you can notice, the slope of these vectors is different, because this intervention here is more cost effective than another one. Both are in the upper right quadrant. Not both increase life expectancy or both are effective, but both increase healthcare expenditures. But the vector is different. You can see that the vector of the most cost-effective intervention is different than the vector of the less cost-effective intervention. So this was the main component of our research, because if we know the incremental cost-effectiveness ratio, the ICER of an intervention, then we can calculate its vector of influence on life expectancy and healthcare expenditure at the population level. This is the equation 1 in our manuscript, and if you are interested, you can find all the details in the appendix. Because this is the equation for the slope. So the ICER is one of the components that will define the slope of the vector for that particular intervention. And if we solve for ICER, that we can estimate the ICER that is consistent with the slope. And now I will explain this better. I think that with the example is easier to understand. But in the appendix of our paper, you can find all the details on how, if we know the slope of the vector, we can estimate then a threshold that will be consistent with that slope. So the relation between the ICER of new interventions and the rate of increase in health expenditures and life expectancy at the country or healthcare system level is the basis for our estimation of cost effectiveness threshold. Why? Because if the cost effectiveness threshold can be calculated, it's something that if we know this relation between the ICER and the slope, then the cost effectiveness threshold can be calculated so that the vector of influence of new interventions will exert a neutral influence. This means it will be collinear to what is expected to be the evolution of life expectancy and healthcare expenditure during a defined period. So this is the methodology that allows us to estimate a threshold for each country. And again, now I am going to show an example with numbers. So we can see here, this is an example of the evolution of life expectancy and healthcare expenditure in the Netherlands. We can see here that during this period between 2015 and 2019, life expectancy in the Netherlands increased by 0.6 years and healthcare expenditure by around 5%. So let's say that we consider that this increase in life expectancy and healthcare expenditure is a reasonable goal for the next period for the Netherlands. So if the Netherlands considers that this pace of increase in health expenditure is a reasonable goal for the next period, then the cost effectiveness threshold can be calculated so that the vector of influence of the inclusion and coverage of new interventions in the Netherlands will exert a neutral influence on what is expected to be the evolution of life expectancy and healthcare expenditures. For example, in this case, using the equation that I showed previously, we can see that the threshold will be around 44,000 US dollars in the Netherlands, and all the new interventions that are included in the benefit package in the Netherlands with this cost effectiveness, with this ISER, will exert a neutral influence on the evolution of life expectancy and healthcare expenditure over this resultant vector. No? That is the estimated, the projection of how the Netherlands expect health expenditures and life expectancy to evolve. Also, this approach can be used to estimate how different thresholds will influence the evolution of healthcare expenditure and life expectancy in the Netherlands. For example, if the Netherlands choose a threshold of 2 GDPs, because this threshold of 44,000 is around 0.85 GDPs. But in case the Netherlands decides to use a threshold of 2 GDP, for example, that means that new interventions the influence of new interventions will represent a vector that will promote an increase in healthcare expenditures of around 12%. So there is no reason for the Netherlands to choose a threshold of 2 GDP per quality unless they consider that an increase in 12% in healthcare expenditures during this period is a reasonable goal. And under this approach, we provide guidance cost effectiveness threshold for 174 countries, but this is very important. We estimate this threshold assuming that the median increase in health expenditure and life expectancy in countries with a similar income level is a reasonable goal. And of course, we know that this is not valid. It's a not valid assumption in many countries, and we discussed the case of India in our manuscript, and that is why we are working now in an updated methodology. In the paper, you can find in the main table the thresholds that we estimated for different countries, and in the appendix are the thresholds for all countries. In general, our results show lower threshold relative to GDP in lower income countries, in contrast to high income countries. For example, only in 26% of high income countries, we observe threshold per quality below 0.5 GDP, as opposed to 96% of low income countries that we found thresholds below half GDP. Our results also show significantly lower thresholds than those postulated in the past by the WHO, and also lower to those currently being used in many countries. So this means that many decisions today could be being made with incorrect information. Also, we provide an online tool that allows different countries or healthcare system to update, to estimate their own thresholds. One of the advantages of our approach is that it allows to estimate thresholds for different health subsectors in the same country, because it uses different input. It's not we estimate, it's not just at the country level. It can be used to estimate also thresholds in fragmented healthcare systems. Our results can be used as a reference in more than 100 citations so far to estimate the cost effectiveness of different interventions in high-income countries, in low and middle-income countries as well. And so at that point, our conclusion was that, or it is that our decision rules for the allocation of health resources that do not prioritize based on appropriate guidance, either by the lack of cost effectiveness threshold or because they're using a misguided threshold, this will lead to suboptimal solutions, which can result in reversing interventions that are not cost effective or in limiting access to effective and efficient interventions. However, we know that currently there is no method that can be considered the single best to empirically estimate thresholds. So we hope that the development of alternative approach is an important contribution to inform the selection of cost effectiveness threshold and improve the evidence base of priority setting. So this is what we have published so far. But we know that the assumption that all countries should target the median growth rates in life expectancy and health expenditures may not be valid in all countries. A country might prefer different targets of health expenditure and life expectancy that are not the typical for countries in the same income level and for different reasons. In the original paper, we discussed the case of India. For example, in India, healthcare expenditures per capita represent just around 3% of the GDP of India. And this is a very low value, even when you compare this value to other countries in the same income level as India. In the same income level, countries usually use around 5% of their GDP to health. That is more than the 3% that India is currently devoted to health. So, for example, in India could have reasons to be more ambitious when defining a target of health expenditure increases, and this will affect the threshold estimate. And why this is an important component? Well, we know that there is a relation between the budget and the threshold. This is a very well-known paper from Anthony Collier. That we can see here a representation of the threshold, that is this one, based on the budget available. And if a country needs to reduce the budget, then the threshold will need to increase, and the opposite, if a country can increase healthcare budget, then the threshold can be reduced. So there is a relation between the budget and the cost effectiveness threshold. And for countries like India, for example, if they are willing to increase healthcare expenditures in the future, that is something that will affect the estimation of the threshold. So that is what we are working now with our new approach. Because to address these considerations, we updated our framework to incorporate GDP growth projections and specific context-specific characteristics that allow us to adjust the thresholds for each country. And I'm going to show this with an example. Suppose that we are talking now about upper middle income countries. In upper middle income countries, the median for all countries, the median expected annual increase in life expectancy is around 0.2 years. And the median expected annual increase in health expenditure per capita is around 2.8%. So using our equation, we can estimate a threshold based on these assumptions. But again, this is assuming that behaving like the median in your income group is a reasonable target for all countries in that income group, and that maybe is not the case. For example, for China, if we use the data of life expectancy and healthcare expenditure of China, using our equation and based on these targets, we can estimate a cost-effectiveness threshold for China for around $8,000. That is around 0.63% of GDP. But we also can consider other aspects, more contextual aspects. And here you can see a series of countries. These are all upper middle income countries. But I am showing here the proportion of GDP devoted to health. And you can see that China is in the lower third because it is devoting just 5% of the GDP to healthcare. So in these countries, for countries with health spending relative to GDP in the lowest third of their income group, we calculated an additional target increase in health expenditure per capita because China can be more ambitious in the increase of health expenditure per capita. So instead of 2.8% as the median of other countries in the same income group, we estimated for China an additional increase in healthcare expenditure of 2.2% to a total of 5%. Why? Because this is the increase in health expenditure per capita that will allow India to reach the median proportion of GDP devoted to health in 10 years. So as you can see, this is a more ambitious target. And under this new target, of course, under the assumption that China will increase healthcare expenditure by 2.8% as all other countries in the same income level, that resulted in a threshold of $8,000. But under this new assumption that China can increase or can set a target of increase of 5% in healthcare expenditures per capita, that will estimate the threshold to $14,000. That is 1.15 GDP. But this new threshold is higher, of course, and why we consider that this new threshold is more reasonable for China? Well, you can see here the expected evolution of healthcare expenditure in China under these two thresholds. And you can see that under the original threshold of $8,000 that was estimated with our previous methodology, the proportion of GDP devoted to health in China will decrease because we are also taking into account the projections of GDP growth by the International Monetary Fund. But under this new threshold of 1.15 GDP, in the next 10 years, China can reach this target of 6% of the GDP devoted to health. Of course, this is a decision that needs to be made at the country level, but we consider that these new thresholds are more context specific and reflect better the situation of each country. Also, in the new paper, we provide thresholds estimation for around 180 countries, and also we compare the threshold estimated with our previous methodology and with the new methodology, and you can see here the case of China comparing both thresholds. And I think that we can leave questions. Well, if you have questions now, I will stop sharing.
Yes, I think maybe Paul has told us that the Q&A session will be at the end, but I think there were already two interesting questions. So maybe we can have a slot here for the questions for this first section. Charlie asks if we have applied this approach to DALIs as well as to life expectancy.
Yes. Yes. I show the examples with life expectancy because it's easier and it's more intuitive, but the actual estimation, we present the results per life year, but the main result is per quality adjusted life year.
Yes,
because that we know that is the most important metric. So the main result is in quality adjusted life year, but the examples are in life years because it's easier to understand.
Yes, and qualis are very similar conceptually to DALIs, so it's just they see more the burden and not the healthy life, but it is extrapolable or transferable to DALIs as well. And then Paul asked if this methodological approach is based on the influence of resultant vector, where we capture the effect of differential time horizons of the determinants that act as the vector of influence.
I will think that's a difficult question, but there is a previous question also from Martina that I would like to answer regarding how can this threshold be customized to countries with limited resources. I am not sure, Martina, if you are referring to limited data, but I think that one of the advantages of our approach is that you don't need a lot of data in order to estimate, for example, the opportunity cost. That is another potential approach to estimate threshold. I am not sure if that was your question, Martina. If you mean limited health resources, then the approach is the same. And of course, we estimated much lower thresholds in low and middle income countries, not only in absolute terms, but also lower thresholds in terms of proportions of GDP.
Yes, I meant limited data. It's really difficult to find data in this context.
Absolutely. That's why we think that this approach is useful precisely in low and middle income countries, because you just need to estimate the projection of life expectancy and healthcare expenditure increases. And that's the only data that you will need at the local level to estimate the threshold. I am not sure if I... Yes, Pavitra, yes, you are right. Of course, it's very difficult to estimate a resultant vector from now for the next 10 years because there are many factors. And of course, there are a lot of factors that are outside the healthcare system that cannot be estimated. So our approach is not trying to establish a causal link between health expenditure and life expectancy. We know that there is a relation, and of course there is an influence of healthcare expenditures on life expectancy, but also there are many factors that will also influence life expectancy: a war, improvement, social improvements, many other factors that cannot be measured. So our approach is based on estimating a reasonable target for the next year, for example. No, it's not for the next 10 years. And the threshold can be re-estimated every year based on this assumption.
Good. If there are no other questions for this section, we can go ahead with the affordability one. Excellent. So I assume you are seeing the screen. Great. So now we change gears to this idea of how to give useful information to countries or to settings that are concerned or are worried by affordability issues of new health technologies. No? So that was our main question and our main idea, no? How to be able to provide some useful, simple, and practical information for countries that want to assess affordability and want to make decisions and have some useful decision rules or decision guidance about that. So this is the preprint that you can access at this link below, and we hope that this paper will soon be published. So as we mentioned in the initial part of the webinar, affordability is increasingly important alongside cost effectiveness. So one is more relative efficiency, relative value, and affordability relates to more absolute value, no? More financial impact and stress on healthcare budget in this case, no? And in the affordability case, there are very few theoretical work in order to inform or to help us to derive an affordability threshold. No, it's really scarce, the literature related to how to define an affordability threshold. No, which are the theoretical backgrounds. There is one paper published by Loma, so from the York team, but there is really very little theoretical and conceptual work on that issue. So our humble and pragmatic objective was to say, okay, let's review all the literature we have, all the effective cases. Let's find cases in the world that are using budget impact thresholds to either to make technologies to pass through a different mechanism, such as NICE in the UK, or to define different categories of budget impacts, to be able to do some triage and make different potential mechanisms or price negotiations, etc. So let's find all the budget impact thresholds that there exist in the world and try to digest them, try to assess them, and try to come up with some orientation, some orientative thresholds for countries that don't have them or that want to have some information related to that. So what we did was a classic systematic review with a traditional protocol that is published in the Prospero database in CRD. We did our search for one side in the classic literature databases, and we are updating it also now. We also did some manual searching in websites that like such as ISPO or IHEA or Inata Networks or the networks of the Americas, BRISA. And we also, as we are members of Inata, we are members of Redezza, we are members of, or we work with Asia, with HTA, Asia Link. We also surveyed these networks in order to try to retrieve all the cases in countries that use some guidance or some budget impact threshold. So our inclusion criteria were studies or reports or abstracts, in the case it were abstract, that detailed a current budget impact or affordability threshold used by national or regional healthcare systems that were used, not a theoretical threshold or a suggestion from an expert. No, they were budget impact thresholds that were currently in use in countries or healthcare system. So we did a classical screening of the papers and then data extraction that was done independently by pairs of reviewers, and disagreements were solved by a third reviewer or by consensus. So what we did was first to extract the budget impact threshold in the local currency, in each country. In the UK were pounds, in the US were US dollars. So the next step we did was to standardize them to a useful currency in a way, for all countries. And we report them as incremental annual health expenditures per capita per 1 million inhabitants. Yes, so we use the original budget impact threshold, and we standardize it by the per capita health expenditure in a country. So in order to transform all budget impact thresholds to a useful way of reporting it and to a way that could be understood in all countries. So, for example, the NICE has this, what it's called the budget impact test of 20 million pounds. So how we translate these 20 million pounds to a currency that could be useful for all countries. Okay, 20 million pounds, the inhabitants in England, and the health expenditure per capita. That means that this budget impact threshold is related to 113 incremental annual health expenditure per capita per 1 million population. Another way of seeing it is, okay, what proportion of the total health expenditure this implies? But as humans don't like small numbers, this is okay. We could also report, and we report it in that metric as well. But so in England, if a technology increases a little more than 1% of the total 1.1% of the total health expenditure, this will be considered of high budget impact, and will go through a different decision process. So these are the two ways of reporting it: numbers of incremental annual health expenditure per capita per million population, and as increase in total health expenditure. So what we did is to transform each one of the budget impact thresholds that we found to these two metrics. We define categories of budget impact threshold, from how to define something that from negligible to low, moderate, high, and very high budget impact thresholds. So to have more options if you want to define budget impact categories, and using these data points that we found in the literature, we extrapolate these thresholds to most of the countries in the world using the 2020 World Bank data. Well, this is the PRISMA flow chart that you probably all know from systematic reviews. From about 3,000 hits or records that we found examples of budget impact thresholds in 11 countries. As you see, most of them are high income or upper middle income. And this is the list that you see in this slide. So we extracted all the data. This is not for you to see, but we give a description of each one of the thresholds and countries that use them, which agency or in which healthcare sector is used, how it is defined in the local currency, what implies this threshold, if it's a different mechanism for negotiating with a producer, or a mechanism to do a more thorough HTA and cost effectiveness analysis, etc. This is an example. For example, in the US, we detected and we retrieved the ICER definition, the Institute for Clinical Economic Review. There is a private HTA agency that calculates this related to the cost of producing a new drug or making a new FDA drug approval. That's the case and the rationale for the United States, or we have also some examples and description for Singapore and the other countries. So what we did with all these examples of budget impact thresholds, we translated them to the two metrics that I told you about, incremental per capita annual health expenditure per million inhabitants, and also as total healthcare spending in the country, and we rank it. So, for example, the smallest threshold that we found was the one used in Scotland, that it's about 27.8 incremental per capita annual health expenditures, and the more generous, if you want, threshold was the one found in the United States, that is about 300 incremental health expenditure per capita per million inhabitants. So after that, what we did, we did some very little statistical analysis regarding quintiles and the distribution of these thresholds, deliberations among the study investigators, and we are proposing or suggesting these three different thresholds that separate the technologies in 4 budget impact categories. No, so if the incremental cost is 50 or less than 50 per capita health expenditures, it's a low budget impact area. If it is between 50 and 100, it would be in the moderate budget impact area or category. If it is from 100 to 200, it would be high budget impact category. And if it is above 200, it would be in the very high budget impact category. This is summarized here below, both in these 2 metrics that we chose to report our results, no? This incremental per capita health expenditures and the fraction of the total health budget that would correspond to these per capita health expenditure categories. And we use this data to extrapolate and to report all these 4 categories in these 182 countries using local data of health expenditure per capita and of health expenditure in each one of the countries. For example, in India, if we want to use the moderate budget impact threshold, we estimated as using the health expenditure per capita in India, and it would be about $8 million to consider a new technology in the high category, that it's from 8 million to 15 or almost $16 million, or 100 to 200 per capita health expenditure per annum per million people. And we report in the paper these 4 categories in these 182 countries, and we also make summary tables for different countries according to income, from high income to low income countries. A note of caution regarding this work. No, as I said in the beginning, there is very little theoretical support for budget impact threshold, but they are in use. No? They are, at least we found that in 11 countries in the world, there are several examples of different affordability thresholds that are currently in place. So our thresholds have no conceptual or theoretical basis. No? This is what we found that is used in different parts of the world to define budget impact thresholds, but we are agnostics, or we are agnostic regarding the theoretical background of the conceptual background. No? And it's also something that we, as they have not a strong methodological or theoretical background, we also don't give strong recommendations for countries to use them or to adopt them. No, it's something that to be put as an orientation and as a possible tool or guidance for countries that want to incorporate some kind of affordability thresholds in their decision-making process. So, to conclude, we made a comprehensive overview of current global affordability thresholds and their implications for healthcare coverage and reimbursement. We define and propose 4 high budget impact thresholds for different impact threshold categories, from low to very high, that could be used for any country or healthcare system along the globe. One additional advantage that this approach could have is that in many countries we have fragmented healthcare system with different sectors, with different healthcare spending per capita in different, for example, the public sector versus the private sector or the social security sector. So this method could be easily adapted to derive contact or healthcare sector specific budget impact thresholds. So it could be easily extended to fragmented healthcare systems. And we offer a critical evidence-based guidance on affordability decision rules, and we extrapolate them and apply them to these 182 countries, and we expect that this can help also to standardize practices and recommendations alongside the globe. Excellent. So we are arriving to the end of our webinar or our slides. Just to wrap up, Andres, maybe you want to chime in here, no? So we started with the well-established decision rules for quality, safety, and efficacy that are guarded by these regulatory agencies. That these are well-established and uncontroversial, I would say, although there are controversies regarding the fast tracks of some drugs or the evidence criteria, no, that they require for some fast or high needed technologies that could be different, no? But what we reviewed in this webinar and in our work in the last few years is how to provide guidance regarding how to better inform efficiency, have decision rules for efficiency, and that would mean cost-effectiveness thresholds, and also some decision rules for affordability or budget impact thresholds. So we hope that this budget impact threshold paper will soon be published in the upcoming few months. So that's to be continued. And that's where our presentation ends.
I think, Federico, maybe I can add something mainly regarding the motivation for us for doing this work. We have been working in the last 20 years mainly in low and middle income countries, in Latin America, but also in Africa or in Asia. And we have been working during this year helping countries to establish HTA units or HTA process or economic evaluations. And what we still see is that many low and middle income countries, they are still making decisions regarding the inclusion of new drugs and technologies in benefit package without taking into account the economic evidence, without knowing if that intervention is cost effective or not. And that is really a very inefficient way of making decisions. And there are many reasons that explain this. Of course, doing economic evaluation is complex, requires data, requires researchers. In many lower middle income countries, they do not have the resources to do this. But one barrier in many countries is that they do not have a threshold to which compare the results of the economic evaluations or to estimate the budget impact of interventions. So with our work, we try to provide a benchmark or an initial guidance for countries, also for high-income countries, because there are still many high-income countries that still do not have a cost-effectiveness threshold. And there are other methodologies, of course, to estimate mainly to estimate cost effectiveness threshold, but most of those methodologies requires a lot of data not available in many countries. So that our intention was to fill that gap, no, and to make easier the decision-making process in mainly low and middle income countries. No? That's why we are working on this topic. So I think that if you prefer to make questions in the chat or open your microphones, Pavitra, you can tell us how you prefer to continue. I think it was too much. Yeah, I am afraid maybe it was too boring and too technical. It's complex. My English is not the best one, so it's a complex topic in a complex language for me, but hope it was useful for you.
There is a question in the chat box.
Mary, your question is regarding the budget impact threshold, cost effectiveness, or both?
Both. Thank you.
I think that our approach is useful in countries that have different healthcare systems. Is useful for a particular HMO or insurance company to estimate its own threshold. I am not sure how that can relate to premiums for insurers.
Yes, I think that these thresholds are, well, mainly targeted to individual technologies. No? So say, okay, we have to decide if drug A or B is good value for money or has a high budget impact or not. But I think there could be a way to use this to estimate insurance premiums regarding how stringent one wants to be regarding cost effectiveness and how stringent or not one wants to be regarding coverage. In fact, in the US, for example, I think there are these insurance formularies that have different categories of co-payments, no? For example, for different kind of drugs regarding how cost effective they are or how much budget impact they are. So I think there could be some use in that area.
Yes, I think, Federico, well, one approach, of course, can be that you can estimate, no, in a company with this premium that allow us to cover interventions under this threshold. Under this another premium, we can cover under this another threshold. No? It is possible, of course, to estimate the relation between the premium and the potential threshold that can be used to select interventions. I don't see more questions in the chat.
Maybe we give people 13 minutes back.
Now, if no questions are there, so thank you very much for guiding us in our work with your insightful thoughts. Indeed, it is definitely not only a new approach, but it is very helpful for the countries where the data constraints are very high. So at the same time, when we introduce something new, we need some kind of objective evidence instantly. It may not be over a period of long horizon, but it gives something as an evidence for decision making with objectivity. So in that context, definitely this approach is having a lot of utility value, particularly when we are constrained with the available data.
Yeah.
Thank you very much, Andre and Federico again.
Our pleasure. I don't know if you are going to post this webinar in the social network of IHEA, maybe Sophia. Let us know, and we can repost it or
What you can do, you can write a
Yeah,
summary
it'll
blog
actually
post.
be it'll be up within a couple days, probably by early next week.
Okay, so you can send us the post and
Yeah, absolutely. Jacelyn will be in touch. She's the communications lead. So I will have her forward it. If you want to just, if you don't mind just dropping your emails in the chat, and I will take note of that, just in case I don't have it.
Alrighty.
Thank you so much.
And
Excellent.
Andre, Federico, one more request. You may decide to write some blog post about maybe 1,000 or 1,200 words in a language that could be easily comprehensible for the non-health economists.
Sounds interesting.
Yes, and it is a very simple way of presenting for the people who are not having the formal training in health economics, but they're professionals, they're having some role as an actor.
Okay, sounds good. Luckily, this is not recorded, so words can fly, but we are okay with that.
Yeah, please, that will be very nice of you, because we our work must enlighten the people who are actually in the operation, who are the actors in the system.
Right. You have a newsletter, an IHEA newsletter, or
Yes. There is a newsletter in IHEA. Also, there is a platform in IHEA where you can post your blogs.
Good. Okay, we can talk about offline.
Yeah, please. And 1,000 to 1,200 words would be enough. Basically, I'm talking about not more than 3 pages.
Good.
Okay, thank you very much again. And I'm indeed privileged to get to know you. And
Thank you,
I'm very happy
everybody.
that something which is practical for the countries where the data constraints are very high.
We understood. Perfect.
Thank you.
Bye-bye.
Bye-bye.